Hi class, now we're going to cover chapter 24 or concepts of care for patients with non-infectious lower respiratory conditions. When we talk about concepts of care for non-infectious lower respiratory conditions, the book referred to this as the tubular system because it's composed of the trachea, two main stem bronchi, thousands of branching bronchi and bronchioles, the alveolar ducts, and into the alveoli. We talk about the priority concept of this chapter being gas exchange. The interrelated concepts, though, are perfusion, inflammation, and cellular regulation. So one of the main topics in our book was asthma. It's a chronic disease that occurs intermittently, inflammation in airway, tissue sensitivity, and a course of bronchoconstriction. At the alveoli, where the primary gas exchange occurs, there are many structures that can be reduced, leading to a systemic perfusion and gas exchange impairment. These problems tend to be chronic and progressive, needing lifestyle changes. Asthma is a good example of this. Chronic asthma disease can be reversible if properly managed, but it's acute airway obstruction caused by inflammation. That's one of our biggest problems. So as far as etiology and genetic risk factors for asthma, this occurs in response to specific allergens, general irritants, microorganisms, aspirins, and NSAIDs. There has been a genetic component stating that if you have a mom or a dad who has allergies, you have a higher prevalence for having asthma. So asthma incidence and prevalence can occur at any age. 22 million adults in the US and Canada have asthma. It's more common in urban rather than rural settings, and you want to think about those environmental exposures when we're considering that. A really great picture showcasing what happens during an asthma attack. In asthma, we're noticing that we have all those secretions there kind of blocking off that airflow or the gas exchange, and that causes those alveoli to react to it because they are not able to expand like they normally would, allowing for that to happen. So as a nurse, we have to assess. We need to recognize those cues for our patient. What's their history? Do they have any of these allergy exposures or an increase in their IgE levels? For a physical assessment, are we noticing that our patient has some wheezing lung sounds? They could be chronic. That patient might present with a barrel chest appearance, hypoxia, blue nail beds. Again, with diagnostics, we're going to look at ABGs, but we're also going to look at an IgE level for that increase for allergic asthma, sputum cultures to make sure it's not infectious. We're going to look at the pulmonary function tests. Those are used to diagnose asthma through airflow limitations, which are increased by 12% or more after treatment of a bronchodilator. We can also have the patient have an induced asthma attack with methacholine that causes that bronchospasm in asthmatic adults. We've got our assessment. We know our patient has asthma. We start talking about those interventions to help them control their disorder. Self-management is super important. This can be achieved with education on medications, rescue versus continuous therapy, smoking cessation, avoiding triggers like allergens. Drug treatments are based on severity. We have control therapy to reduce the airway sensitivity. We have our reliever drugs or our rescue drugs to stop an attack once it's started. Normally, we have short-acting beta-2 agonists like corticosteroids that are utilized. As a care provider, we need to educate not to overuse these medications as they can increase the heart rate and strain on the cardiovascular system. Other treatments can be cromolyn to decrease the inflammatory response, leukotriene modifiers to block the allergens, monoclonal antibodies to bind and block pro-inflammatory cytokines or surface cell sites of IgE that trigger antihistamines, and then anticholinergic drugs, so long-acting muscarinic antagonists that can block the parasympathetic nervous system. This increases bronchodilation while decreasing pulmonary secretion, so it's a 2-for-1. But we want to make sure that that patient is drinking plenty of water with anticholinergic drugs as they will have terribly dry mouth. Rare treatments, but I still want to mention, would be the methylxanthines like theophylline. These are only used when the treatments aren't working. They have a lot of dangerous side effects, and you have to monitor your blood serum levels because they can become toxic. I think it's super important that with our asthma patients, we also encourage them to take action. We talk about when and when not to use oxygen therapy. We talk about increasing their ability to do exercise and activity because that increases their endurance. More endurance, less stress when they're having that asthma attack. They're able to manage it a little better. Patient with status asthmaticus can be very, very scary. It's severe, it's life-threatening, and it's that acute episode where the airway is obstructed. It intensifies once it begins, and it often does not respond to common therapy. Can develop a pneumothorax or cardiac or respiratory arrest from status asthmaticus. Treatment's usually IV fluids, potent systemic bronchodilators, steroids. We can give epinephrine, oxygen, but it's also important that that nurse in the back of her mind is thinking that this patient may need intubated and I need to prepare for that. So when we think about COPD, that actually includes emphysema and chronic bronchitis. That's a gas exchange issue where we have an obstruction in that pulmonary. Again, COPD includes emphysema and chronic bronchitis. It's kind of divided into those two. They can also be mixed or combined. For the etiology, genetic risk, and incidence, cigarette smoking is the greatest risk factor. Alpha antitrypsin deficiency is also a risk factor. 15.7 million people in the United States have issues with COPD and 800,000 in Canada. Complications with COPD include that low oxygen, acidosis, respiratory infections, cardiac failure, dysrhythmias, and respiratory failure. So when I'm assessing this patient, I'm looking at their risk factors, their history of smoking, any trouble breathing, what's their activity level, and what is their weight. Physical assessments, their general appearance, are we noticing that they have any change in how their chest presents, any respiratory or cardiac changes, and how are they acting? Are they anxious? Are they depressed? Are they moody? Again, we're looking at those laboratory assessments, our ABGs, we're checking to see how their electrolyte panel is, the imaging with a chest x-ray, a CT scan. This is another one where we can use those pulmonary function tests to really diagnose how their breathing is. Then we walk into how we're going to prioritize our interventions for our patients. So the priority for our patients with COPD is to decrease that gas exchange issue. We want to talk about weight loss. We want to talk about their increased fatigue and their potential for pneumonia because of the air trapping. During our planning and implementation, our goals are going to be to improve that gas exchange, prevent weight loss, improve endurance, and then prevent respiratory infections. When they get them out of their initial emergency, we're going to talk about home care management. These patients may now need oxygen therapy and what that might look like for our patient and what risk factors we want to talk to them about. Again, we talk about that patient smoking with oxygen on, terrifying when they blow themselves up. Self-management education, taking those medications, those slow, deep breathing techniques to kind of help them, and what healthcare resources they have in their community to help them manage their COPD. Finally, we evaluate our outcomes. We attain and maintain that gas exchange at a level within their chronic baseline values. We want to achieve an effective breathing pattern that decreases the work of breathing. We want to maintain a patent airway, achieve and maintain a body weight within 10% of their ideal weight, have decreased anxiety, increased activity at an acceptable level for them, and then avoid those serious respiratory infections. The next respiratory issue that our book discussed was cystic fibrosis, and this is an autosomal recessive genetic disease. It blocks the chloride transportation in cell membranes. They develop a thick, sticky mucus. So this not only affects our respiratory tract, but other systems in the body that we'll discuss. It affects lungs. It affects our organs such as the stomach, the liver, pancreas, their growth, their bowels, and their mouth sex organs. So how does this patient present? From their non-pulmonary symptoms, they have abdominal distension. They can have GERD or a gastroesophageal reflux disease, rectal prolapse, foul-smelling stools, or what's called steatorrhea, which is fatty stools, malnourishment, vitamin deficiencies, diabetes, osteoporosis, and osteopenia. They're normally diagnosed by 2 because of their poor growth, They also will have issues with male sterility, cirrhosis of their liver, and impaired gas exchange through respiratory infections, chest congestion, and sputum production, and then they will have limited exercise tolerance. So our interventions, how are we taking action? Nutrition management with some foresight with diabetes management. We're going to replace those pancreatic enzymes. We're going to use positive expiratory pressure therapy or PEPT. We're going to use CPT or chest percussion vibration therapy, and this is used to promote that loosening of secretions and drainage promotion. We're going to use high frequency chest wall oscillation, again for increasing that coughing and mobilizing those secretions, and daily medications such as bronchodilators, anti-inflammatories, mucolytics, and antibiotics. These patients will also be talked to about how to help during an exacerbation period and gene therapy. So there is surgical management with cystic fibrosis, but it consists of lung transplant, and this doesn't cure it. It can extend their life by 1 to 15 years, but they will have transplant rejection medications for the rest of their life, and their rejection rate is very high. So they also are at extreme risk for lethal pulmonary infections because they can't clear them. Moving on to pulmonary arterial hypertension. This is where the pulmonary vessels and other lung tissues undergo growth changes that greatly increase the pressure in the lung circulatory system, and it's for unknown reasons. This can cause dyspnea and fatigue. We treat this with drug therapy and oxygen. We can also do surgical management such as lung transplant or heart-lung transplant, also known if it's an issue with cor pulmonale. Patients can also suffer what's called idiopathic pulmonary fibrosis. This is common restrictive lung disease. It's a progressive disease with few periods of remission. After the lung injury, inflammation continues beyond the healing time, causing fibrosis and scarring. We treat this with drug therapy. It's important that these patients have community resources and education about their home oxygen. We talked about head and neck cancer, but there's also lung cancer. And unfortunately, these patients have a poor long-term survival. It metastasizes often. There's a perioneoplastic syndromes they can have, and we often go into staging with these patients. So when we talk about incidence and prevalence, this is that repeated exposure to inhaled substances that cause chronic irritation and inflammation. And I know I feel like I'm harping on this, but cigarette smoking is one of those major risk factors for this. When we talk about that cigarette smoking, though, I want you guys to know, like, you can be a non-smoker and still end up with lung cancer in regards to secondhand and third-hand smoke. That is also a risk. Chronic exposure to chemicals and inhalants is the other one. Sometimes occurs in adults who've never smoked. Like I said, that woman whose husband smoked, she can develop lung cancer and had never smoked a day in her life. With that lung cancer, we're looking for them to reduce or stop smoking. We're looking for that secondary prevention, trying to see what has caused them to have this. Are they exposed to chemicals at work? Minimizing that to help us prior to the treatment of the lung cancer so that they have the best chance of survival. When we first have this patient present to us, a lot of times with lung cancer, we'll look at those risk factors. We'll talk to them about how they're presenting to us with hoarseness, a cough. They're having increase in sputum. They're noticing blood in their sputum, increase in shortness of breath. You know, they used to be able to run 5 miles. Now they can barely make it a mile and they can't breathe, developing that chest pain. We talk to them about any signs or symptoms that are pulmonary versus non-pulmonary, and then how they're feeling. That psychosocial aspect is super proponent here. Is my patient depressed? Are they anxious? Are they tired? What's going on with them? A little bit before, but we always start our assessments with the most minimally invasive, followed by the invasive. So we'll start with the blood tests. We'll assess for an increase in their WBCs. We'll run ABGs to see if there's an impairedness to their gas exchange. We'll do a chest x-ray. We see a mass on a chest x-ray. We'll do a CT. A mass on a CT. They'll talk about doing a biopsy or a pleural effusion fluid drain. If they get that back, it's showing that it's cancerous. We might do an MRI. We might do a radionuclide scan or a PET scan. And then we'll go in with that a more invasive idea, which is that thoracoscopy, go in and actually take a sample of the lung to assess what's going on with our patient. Management of lung cancer, similar to treatment with other cancers, we're going to use that non-surgical management with chemotherapy, targeted therapies, immune therapy, radiation, and photodynamic therapy. And then we'll do that surgical management, which is that removal of the lobe or the entire lung. These patients may come back with a chest tube just to help promote that space to be clearing and also make sure that our patient's not having issues with that fluid staying in that space. Surgical terms you may hear with lung cancer would be a lobectomy, a segmenectomy, resection, or a pneumonectomy. As we talked about in the last slide, there is a chance your patient could come back with a chest tube. And again, the image to the right demonstrates proper chest tube placement. I get nervous when we talk about chest tube drainage systems because I feel like I've seen so many of these working at different hospitals, but this is a pretty standard one. This image shows a chest tube drainage system on the left and a diagram of the sections and the flow through the right side, how the air goes through when our patient takes in a breath and when they exhale. This collects all of that fluid that's post-surgical. So lastly, we're going to talk about the interventions. When we have a patient coming back, we're talking about how we treat them palliatively. So these patients will have oxygen therapy. We may talk about radiation therapy to try to take care of any cancer that may come back. This patient may have a thoracentesis. We're going to manage their shortness of breath and pain. And then this patient may also be up for hospice care. End-of-life care is a topic we do discuss later in this class, but just to talk about it a little bit, when we talk about a patient who's having trouble breathing, a lot of times that increases anxiety and depression. So just being there for that patient and getting them the resources they need to have a fulfilling end of life is super important.